Okay, well, I'm Bruce Cruser, Executive Director of Mental Health America of Virginia.
My name is Dr. Alyssa Ward. I am a licensed clinical psychologist and the Behavioral Health Clinical Director at the Department of Medical Assistance Services. I'm also an affiliate faculty member at Virginia Commonwealth University and practice at the Children's Hospital of Richmond.
My name is Albie LaFave. I am the mitigation specialist at the Charlottesville Albemarle Public Defender's Office, and I've been doing that work for 20 years.
My name is Anna Mendez. I am the Executive Director of Partner for Mental Health. I am also the Board President of Mental Health America of Virginia. Please join us in conversation. For me, what started my journey and commitment to increasing access to mental health care in Virginia was doing medical social work at a very rural, federally qualified health clinic in Highland County, and seeing the great lengths that people had to go to in order to access mental health care. I'm happy to say that today, 13 years later, you can now go to that FQHC and actually receive clinical care. But at that time, people were making a 90-minute drive one way, if they had access to insurance, which was a really big if. And so just seeing that barrier and what that the impact that had on people's quality of life, and how many people were willing to get help but then couldn't because for whatever reason didn't have the ability to make that 90-minute drive. That was really my impetus for saying we need to change this.
Yeah, and for me, I guess it was working for over 20 years with local probation services in Henrico County, and the constant back and forth of people going in and out of the criminal justice system, and then the obligations that they have to the system as a result of being on probation, when the real issue was an underlying mental health problem, and then the inability of the system to work so that it could help that person deal with the underlying problem, and instead the system punishing the person because they were sick. And that is the thing that still drives me, I think, to want to see better access to mental health care.
Boy, does that resonate with me.
Yeah.
As 20 years as a probation officer and in my current job, I find that we punish people with addiction, right? But how often do we look at the underlying factors that are driving their addiction? I find that most of these people have had traumas or neglect in their lives, and judges and prosecutors have a hard time seeing that, and so we're just kind of re-traumatizing them. And unfortunately, they're not the easiest clients to get services for because they don't have money. They're not very organized, which is why you guys have been so instrumental in helping. We just now have a therapeutic docket in Charlottesville that just started, so I'm pretty excited about that.
Yeah, that's great.
But what are the statistics? How many people, as our recent screening tool saying, in the jail has a serious mental illness?
Every day, at least one person is entering the jail and screening as likely as having a serious mental illness. It's actually really like 1.25 people. So it's more than 400 people a year. And we have a brand new mental health docket here in Charlottesville, but we're not at capacity yet, and capacity will probably be about 30 people. And our Region 10, our Community Services Board, provides case management and psychiatric services to people that are leaving the jail, but their capacity to do that is around 50 to 60 people a year. So there's there's a gap.
Mm-hmm.
There's a gap there.
It's interesting because while my career has not focused on corrections
Mm-hmm.
or the folks that you're talking about, some of my initial values around access to mental health care were driven by similar observations, but from a more personal spot because I was raised by a police officer. My mother is a community police officer. And the stories from her throughout her career of really functioning as a social worker as much as a police officer, and seeing the need for mental health support for those that she was working with and in the community made a big impact on me, and was one of the influences in me becoming a psychologist. More recently, since I have returned to Virginia and have been practicing, when I came back to VCU and started working at Shore, what I noticed right off the bat is that most of my patients, particularly my patients who had Medicaid coverage, were driving, like you said, 90 minutes, sometimes two and a half hours, because they're coming for a medical specialty and they have complex medical issues for which they're seeking dual behavioral and physical health support. And really there was just no psychologist, particularly with that kind of specialty, anywhere in their region. And they continue to come. And I continue to serve them, even though I'm in this more administrative role now at TMAS, and I retain that practice at VCU in part because of my concern for their access to care and wanting to continue to provide continuity of care for the population of kids that I was serving. And one of my goals is to put myself out of business in that role at VCU, to be able, with all the work we're trying to do with DBHDS and the community service boards to try to expand access to care and to really build up our workforce and opportunities for kids to get served in other places, so that I can dedicate myself even more to the administrative aspect of this redesign.
It is really, there's so many layers to it, because, you talked about the rural area is not having the access because you don't have the mental health professionals or healthcare professionals in general, and a lot of the rural areas, the transportation and all those challenges. But then you've also got the insurance issues, and you could have the professionals practicing there. You could have, a child psychologist for every kid, but if they don't have insurance, or they don't have some way to pay for it, then you've got that access barrier. And then you have the additional barriers of language and cultural competence. Are the professionals culturally competent to work with the people who live in that particular part of Virginia? And as we know, Virginia is becoming a very diverse state, so you got that issue. And then the thing that we try to work with a lot with Mental Health America is the whole issue of just backing it up to how do we perceive mental health, and to get rid of the stigma and this sort of embarrassment that people might feel, so they don't talk about their problems. And so help may be available. It may be available and affordable and in their language or culturally appropriate, but they have a barrier of access based on the stigma or embarrassment to talk about their problems. So there's so many pieces to this. It's just a challenge across the board.
A huge challenge. And I really appreciate you saying that. I think when you brought up that level of kind of cultural mindfulness and people being equipped, even just language support-wise, to reach people where they're at and allow them that open door, it made me think about some of the instances that I've experienced as a practitioner here of folks of varying documentation status and the contribution in our current climate around legitimate concern about coming forward for behavioral health problems related to trauma, when they're afraid that they may also then put themselves or their families at risk of deportation. And that was something that was on my mind in my last year of practice at VCU, and how to make it a comfortable environment for people to disclose and reach out for support and be able to be there for them.
Sure be nice if the current cost of incarceration is $91 a day for one person per inmate.
Wow.
Think of all the money that we could generate
Yes.
if we diverted some of those people into more appropriate situations.
And I think part of our ability to do that in Virginia is really predicated on transforming the system that we currently have, because we are more highly funding inpatient care than we are community-based care. And so right now, we're primarily, Partner for Mental Health is primarily an advocacy organization. Even a lot of our direct service provision is really about advocacy and getting people the care that they're eligible for. Because until we are better funding community-based services at community services boards, at peer-run centers, just very diversely, until those exist, even people who want care and are willing to receive it can't. And then what ends up happening is their complexity of need eventually reaches the level where maybe they are having interaction with law enforcement, or maybe now they are actually eligible for inpatient care, and then that creates an entirely different cascade of issues as well. We are, like I said, we are primarily an advocacy organization, which means oftentimes, usually people don't come to us until something is not working, right? And as true as that is, I think any conversation about access and increasing access to care is really incomplete if we don't really congratulate Virginia on finally having expanded Medicaid. We're now into day 4 of having expanded Medicaid. Almost 500,000 people in Virginia who didn't have that now will. You would know the numbers better than I do, Alyssa, but something like 30 to 40% of them are predicted to have.
That's right, based on other similar states' data. About 30% of other states like Ohio or Pennsylvania, their expansion population has had a behavioral health diagnosis or a potential need for behavioral health services. So it's significant, and it's also comparable to our current statistics on who within our Medicaid membership has a behavioral health diagnosis and would likely benefit from service. So we do anticipate a need there, but the coverage, like you said, Bruce, is the first step. I mean, making sure that people have the coverage is one of the initial barriers for access, and then there are those regional issues about what services are available physically, even just present, and then also the workforce issues. So who do we have there? What do we have the right providers in the right settings, and are we funding them in a sustainable way to allow them to practice and do the good work?
What do you think that with the expansion of Medicaid that there will be a similar expansion of providers or accessible mental health professionals?
Well, that is our hope, and that's really one of the drivers around our hope of behavioral health redesign for the state of Virginia, is that we know from a lot of data and just a lot of narrative that there are significant workforce issues across the board, that we don't have enough psychiatrists, which is a really significant issue for appropriate medication management. But there are also a dearth of providers in terms of licensed mental health providers across the spectrum, social workers, psychologists, marriage and family therapists, et cetera. And so that is a bigger conundrum, I think, for us as a state to figure out. Like, where I can't say honestly that I completely have a full set of hypotheses yet about where that comes from. Whether it has to do with the functioning of our current system, and so we're not retaining graduates from our current programs, whether they go to other states that have more jobs or better rates or more high-functioning systems. I don't know what it is, but I do know that we have a workforce problem, and we want to find ways to make this system one that is attractive for people to practice in, that innovative, motivating work is going on, and that people want to join that workforce and be a part of it. And from our current state and also attracting workforce from other states who want to come over and practice and be a part of change in Virginia. So I think that's going to be part of the access puzzle.
Yeah. Yeah. I mean, I know our Roanoke affiliate last year sometime was talking about the wait list to see a psychiatrist, even with insurance. And people who had private insurance were having 2-month waits in order to get in. So it clearly is an issue across the board.
It is. I think it's hard to underestimate the impact of the workforce issue. And it's not just that, because here in Charlottesville, we're so fortunate that on a per capita basis, we have more licensed professionals than anywhere else in Virginia, and that has to do with the size of our population and that we have, the university, the university here. And even with that, there are still significant access barriers, and a lot of that, I think a lot of that again is kind of related to our inverted. We're funding inpatient beds more than community spaces, and so until there's some really, really big shifts, even addressing workforce is kind of an incomplete solution, I think.
Well, in terms of the Medicaid-funded system, I mean, we are the largest payer of behavioral health services in the state, and in our recent analysis, we've, working with licensing, we've shown there's like around 2,000 licensed psychiatrists in the state of Virginia. Only 34% of those work within the Medicaid system, so accept Medicaid as a form of payment. But only 28% of that 34% are currently accepting new patients. And an even more interesting piece of data for me was that only 9% of that 34, so we're getting down into very small numbers. 9% of those only have one Medicaid member as a patient, and then 14% have less than 5. So the pool of psychiatrists that are participating in care with Medicaid members is very low. And we know that has to do with the rates, and that's a problem that we need to address and analyze.
Is there more paperwork, more accountability? I get the sense from the Region 10 staff that it's harder work, and clients are not as compliant. And
there's more barriers.
And more accountability in the paperwork, more risk. If you find a patient that's suicided, or so it's like, well, why would you want to put yourself through that if you can make a lot of money in private practice and not dealing with any of that?
You're naming a lot of the drivers, I think, that pull people away from serving, really who are some of our most vulnerable people who, really need to have the most availability of support, and for all of our best interest. But it's because of those very practical factors, I think, for people trying to keep the lights on in their businesses, and the numbers haven't added up, and then there's been these other practical factors. So there's the things that we need to consider when we're trying to make it more attractive.
I don't know how we fix those. They're not easy ones.
They're not easy ones, but I don't think they're insurmountable.
I'm glad to hear you say that.
Yes, so we have to have hope throughout the situation. So we always talk about recovery is based on hope. And but really the reimbursement rates, I mean, if it can be financially advantageous, then I think then clearly that will help a lot. And then having the array of professionals available too, not just the psychiatrists, but backing up we talk about the peer specialists, who are now a new professional certification for people who have the lived experience of themselves with a mental illness or substance abuse addiction, and then it being in recovery and getting the additional training and certification so they can then help others is really, I think, adding a great new tool to the toolbox.
Absolutely.
So that's so important. And then, of course, as you referenced, Anna, about the Virginia's woeful funding of public mental health community services boards. And even with the additional money in the last several years, Virginia is still almost 50% of the national average in terms of how we fund community mental health. And that's going to be, and when we get to that point where we're up to 80%, 100%, then I think we'll see, community service boards all over the state being able to serve people in so much a better way. I mean, there's such a difference around the state, right, with the community services boards where where the locality puts in money in addition to the state, like Fairfax, you've got a whole array of services that Highland County doesn't have because that locality doesn't have the money to put in. So fixing the financing across the board is
that's part of really the impetus behind this redesign is to support the community service boards and the good work that they do, and to support Step Virginia and the hope that Step Virginia has provided around improving our system. Really the goal is to find ways to make funding more sustainable and to find ways to better use our Medicaid funds, to better invest in the services that are going to be more efficacious and more appreciated by people who are participating in those services. And that's a big, long process that we're just embarking upon, but you really hit on what the root of it is. It really is in support of Step Virginia, in support of the CSBs, and trying to be able to better fund using those Medicaid dollars.
Yeah.
We're grateful. We see so many people who have really benefited from the part of Step Virginia that has now allowed for same-day access at Region 10. And so we are incredibly grateful for that. That has opened up flexibility for us. I appreciate it. My staff appreciates it just from a logistical standpoint, but ultimately we appreciate it because it makes things easier and better for the people that we're working to serve. And I also hope that we don't lose sight of the fact that same-day assessment is not the same thing as kind of same-day care. And I know that we have this model in the United, we have walk-in urgent care, right? You don't need to go to the hospital, but you really need to see someone now, right? And you can just go and have your urgent medical need addressed same day. And I am just living for the day where there's kind of there's same day urgent care when you're in distress.
Absolutely. I've also had this kind of career-long dream of, we take our children in for yearly physical checks for school and for their health. Yes. We ostensibly go for yearly physicals, for immunizations and what have you. Why don't we have universal behavioral health check-ins? We talk about breaking down stigma. If that was a universal expectation, that we had those available even in physical healthcare environments where that was just part of the regular checkup and conversation, how would that change our culture?
I will say I was so excited. I took our 4-year-old to her most recent annual physical, and on the counter in the exam room was one of the screening tools and I was just, I said something to her pediatrician and she said, we do that for all pre-adolescent and adolescent kids every time they're here. I said, yay, progress!
I'd love to see that in practice.
Progress. That I think in that whole integrated care model of having physical and mental health looked at together, and the CSBs are charged with starting to incorporate that, right, in the local. So it moves to that model of mental health is part of health. And if we treat it that way and think of it that way, then when your ankle is broken and you say, hey, I need help here, I'm hurting, it would be no different than if you're feeling severely depressed and you say, hey, I need help here, I'm hurting. And that everybody kind of rally around and get you the help just like they would if you're on the floor with a broken ankle. So I think there's movement. I think we're seeing progress that way. even the movie stars who come out, or the
Yeah.
celebrities who are coming out and saying, yeah, I've suffered from severe depression, or I mean, although sometimes I question the motives about that, but the real the impact can be positive, because it means more and more people are being open and honest about that, and that's bound to help.
Well, there's a momentum, I think, that if people feel like the community cares about them, they have a better sense of community, and they want to be part of the community, and they want to help other people. It's sort of a snowballing win-win, I think.
Yeah.
I find in my population sometimes they feel like the community doesn't care about me, so why should I care about anybody else?
Yeah.
Or myself, which
Or myself.
Yeah. What is my value?
Well, and you've probably seen people coming in and out of the correctional system who maybe when they come in, at some point they are evaluated, or at some point they're getting some assistance, but then when they go back out,
Right.
there's no continuity, right?
Before we had healthy transitions, we would have people coming out of prison with no CSP appointment, no medications, and the locality funded the healthy transitions so that they could come out and immediately transition into medication and case management services. But people are just committing crimes to go back in, because jail isn't really as bad as a lot of society makes it out to be for a lot of people. It's three hots on a cot,
Well, we were seeing people with who were eligible for Medicaid on the outside, and then they go in and they're not. But so they lose their benefits. But then when they come back out, it was taking forever to get them back on.
Yeah.
And then we know that most vulnerable period in terms of recidivism is the first 6 weeks when you get out of jail, and that's 6 weeks when they're without their medication, can't get an appointment. So I think there's been efforts to improve that and to tighten that up, but that, that's just, that's a moral failing in my view, because we're responsible for people. If we've said, okay, if you break the law, then we're going to lock you up, we have this law, then we think we need as a society to be responsible for making sure that this person has a better opportunity once they get out. And if they've been getting services while they're in, they should be getting those services when they get out.
It's the only humane thing.
Yeah.
And people shouldn't have to get locked up in
order-
order to
right.
in order to have access to those services.
No.
We're thrilled. We refer quite a few people to healthy transitions, and we're so grateful that it's there. And we wish it was that easy to refer people who hadn't been incarcerated as well.
Well,
Yeah.
I think that's where we're at as a system, and that's a statement about where we're at as a system, is that you shouldn't have to be at a point of crisis or this severe transition in order to have access. And so the goal is really to try to create more seamless access at places like schools and integrated care environments, and to be able to have that be a very easy handoff and transition that is hopefully someday absent of stigma, that it's just like referring somebody to have their ankle patched up.
And there was the legislation that passed last year to require that the health curriculum in public schools include mental health as part of the health curriculum. And so, again, starting when kids are young, seeing it as part of health will certainly pay dividends down the road. And then, the other issue that comes to mind for me is the whole quote crisis we're having with the bed shortage for crisis care and the state hospitals being full. And so when people are in crisis, we don't have enough options to help prevent them, well, A, from getting to the point of crisis, and then B, when they're in crisis, there ought to be other options besides the state hospital or hospitalization. And so that, I know there are efforts going on now to find ways to fund things like psychiatric emergency centers, mobile crisis teams, peer respite centers, so that when people are starting to get to that point of crisis, there's an option locally, in their local community, where they can get help to prevent them from going into full-blown crisis. So I'm glad to see attention being paid to that, and I think that'll be much more cost-effective than building more prison beds or more hospital beds.
It goes back to this idea that we've talked about a lot since I started my position at DMAS, about the fact that we're funding basically fleets of ambulances in our system on roads that have no seatbelts. And so those ambulances are necessary. We need acute care to go out and reach people at the scene of very acute incidents. And when we need to continue to support that, and we're not trying to abandon those people in acute crisis right now, but we also need to pull back and think about how do we improve the safety of everyone traveling on that road. And how do we build seatbelts in? And driver's ed could be an idea of high schoolers, getting mental health education. This idea of building that up, and that takes a long time. I mean, that's the reality in system transformation. It takes a long time to build and sustain the momentum in the prevention and early intervention end of a system to see that benefit down the road. But that's the hard work that I think we need to engage on as a state and across all of us that are working to support people with mental health challenges. We need to start earlier and make that investment, and I hope to see it pay off.